is about screening. In this lecture, we are going to have idea about screening, its definition, and what is a screening test, the difference between screening and diagnostic test, and also criteria of diseases appropriate for screening and criteria of screening tests. We are also going to know about how to calculate measures of validity of screening tests and to have idea about reliability of screening tests and sources of variability. First of all, before we talk about screening, I want you to know or have an idea about the concept of iceberg phenomena of disease. You know that distribution of disease in the community differs from that in a hospital. In a hospital, you see evident diagnostic cases, diagnosed cases, for example, cases of diabetes, heart diseases, and other diseases. But in the community, there are, or the majority of cases are hidden in terms that they are asymptomatic or in the preclinical stage of the disease, so that only the tip of the iceberg represent the evident or apparent cases that are the cases that's seen by physicians in their practice, while the submerged portion of the iceberg represent the majority of the cases which are asymptomatic or hidden from being diagnosed. And these are the cases or the preclinical cases that we are going to screen or we want to detect by screening. So as a definition, screening refers to the application of a test to people. Those people are in their preclinical or asymptomatic stage of the disease for the purpose of classifying them with respect to their likelihood of having a particular disease. So they will be classified into screened positive and screened negative. And of course, those who are screened positive will be sent for further evaluation by a diagnostic test so that appropriate treatment can be given to those detected persons to prevent progression of disease or complication of the disease. So the screening test, as we understand from this definition, it is not a diagnostic test. So we are only searching for those who are likely to have the disease. So the important concept in screening is that early detection before development of symptoms will lead to better or more favorable prognosis of the disease. Because in this period, early detection in the preclinical or before symptoms appear, we can apply appropriate treatment. This treatment is more effective than if it will be given after symptoms appear. Of course, not all diseases are appropriate for screening, and there are certain criteria that should be available to consider a disease appropriate for screening. First, the condition or the disease or the health problem should be serious in terms of morbidity and mortality. So, for example, a disease should be with high prevalence in the community or it has a high fatality rate. Also, there should be a recognizable latent or early asymptomatic stage, because at this period we are going to apply our screening test. Also, we should have a good information about natural history of the disease. That is the onset of the disease and information about the latent period where we can apply the screening test, when the symptoms of the disease will be appear, and so on. Also, there should be, of course, a test that can detect the disease before symptoms appear. This is the screening test. And of course, there are certain criteria. We will take it later about the screening test. Also, there should be an appropriate diagnostic test for those who are screened positive. So those screened positive should be sent for further tests to diagnose if they are really have the disease. And the most important, there should be effective treatment to be given in this stage of the disease. Because if there is no effective treatment, there is no benefit of all screening program, even if there are good screening tests. Also, the important thing that a treatment given before symptoms appear should be more beneficial in reducing the rate of disease, reducing complication of disease, than if they are given after the symptoms develop. Also, the prevalence of the disease or the preclinical disease in the community must be high, because rare diseases, if the diseases are rare, we will not going to detect good number of asymptomatic or cases in the preclinical stage. Also, there should be an agreed on policy concerning whom to treat as patients, certain criteria and standards to be put in advance to treat those who are considered as patients at the end of the screening program. And also, we should have good information and evidence from previous researches or previous screening programs that early detection of diseases will improve the condition in terms of reducing morbidity or mortality. And lastly, the benefits of screening tests must exceed the risk and cost of that screening program. An important question in screening is whether the treatment of a preclinical disease is more effective than treatment given after development of symptoms or signs of that disease. This to be evaluated, first we should know about the natural history of the disease. So each disease or those diseases that considered appropriate for screening have a period after the biologic onset, represented here in A. So after biologic onset of the disease, there is a period in which the disease can be detected by screening test. And the period between the time that the disease detectable by screening test, represented by B, to the C, where the disease can be detected after or diagnosed after symptoms appear, is called the preclinical phase. So this is the screening in which the screening test can be applied. So there should be an effective treatment that when given in this preclinical phase, and it is effective in improvement of prognosis of disease than if it is given after symptoms appear. An important examples on diseases appropriate of screening is hypertension. Hypertension meets all the criteria of suitability for screening. So that hypertension is a serious health problem because it is a risk factor for many coronary heart disease or stroke. And also it has a screening test, which is measurement of hypertension, inexpensive, easy to administer, and all other criteria. The other disease is phenylketonuria, an example of a rare disease, but it is a serious health problem because if not treated, it leads to irreversible mental retardation in a newborn. For this disease is easy to be applied to all newborn babies, and it can, if treatment is given earlier, that it is only dietary restriction for phenylalanine, it can prevent consequences of this disease, even if it is a rare disease. Regarding screening tests, for a screening test to be successful, there are certain criteria to be met. First, it should be inexpensive, easy to administer, with minimum discomfort applied to patients. The other thing, screening tests should be valid and reliable or reproducible. I want you to know some important points as differences between screening test and diagnostic test. First, screening test is done on apparently healthy groups of people that they are without signs and symptoms, while the diagnostic test is applied to an individual with signs and symptoms. Also, the screening test results are final and based on criteria or cutoff point. For example, when we want to screen for hypertension, we have a cutoff point, for example, of 90 millimeter mercury for diastolic blood pressure to be considered as positive for hypertension, while diagnosis results is not final, and it is based, the diagnosis the criteria, based on evaluation of a number of signs, symptoms, laboratory findings, and others. The screening test is less accurate and less expensive than diagnostic test. And also, it is not a basis for treatment, unlike diagnostic test. If positive, we can of course, give a treatment to the patient. And the last thing is that screening test, for screening test or screening programs, initiative comes from investigator or from the agency or from the government to do the screening programs. While for diagnosis, the initiative comes from the patient when complaining from signs and symptoms. The important thing in screening is the validity of a screening test. Validity means the ability of the screening test to do what it is supposed to do. That is, correctly detect those who are positive or truly have the disease, and correctly detect those who are negative or not have the disease. As you see in this figure, the results of any screening test should be put in a 2x2 table, which has, 4 cells, A, B, C, D cells. So the results of screening test are put in the rows, while the columns represent the disease status or results of diagnostic test or the gold standards of the disease. So each cell of this table represent a certain criteria or results of screening. Cell A is the true positives. That is, persons who are screened positive or have results of screening test positive, and they are truly have the disease. While cell D is the true negatives. That is, persons who test negative by screening test, and they are truly not have the disease. Cell B are the false positives because they are the persons who have positive screening test and they are not have the disease. Cell C represent the false negatives that are persons who have negative screening test result and they are having the disease. So for testing validity of screening tests, we are going to measure sensitivity and specificity of that test. Sensitivity, it is, as we said, the probability of testing positive by the screening test when the disease is truly present. And it is measured by dividing A, which is the true positives, out of A plus C, which are all diseased or all truly positive persons. Specificity, on the other hand, is the probability of the test to screen negative when the disease is when the disease is not present. And it is measured by dividing. So we will continue with this table of how to measure sensitivity and specificity, and also the predictive value of positive screening test and predictive value of negative screening test. Predictive value of a positive screening test is a probability that the screening testing positive among truly positive among all screened positive. So it is measured by dividing true positive, that is cell A, out of all screened positive by screening test, which is A plus B. While the predictive value of a negative test, it is the probability that the test is testing truly negative out of all screened negative by screening test. And it is measured by dividing true negatives, that is cell D, out of C plus D, that are those who do not have the disease. So these are the important measures of validity of the screening test. So as we described earlier, that sensitivity is the probability of testing positive if the disease is truly present and calculated by A out of A plus C. Of course, when we increase sensitivity, we know that those or the number of persons with the disease who are missed by being incorrectly classified as test negative will decrease. So increasing sensitivity of screening test will lead to lowering false negatives. While on the other hand, increasing specificity of a screening test will lead to lowering of the false positives. This example of with numbers on how to calculate these measurements of screening test. This example is about screening of a breast cancer. As you see, the rows numbers of the table representing results of screening test, which is physical examination and mammography as screening for breast cancer, and the columns representing the results of breast cancer confirmed by diagnostic test like biopsy. So the sensitivity here measured, and it's found to be 74.6%. Of course, all these measures of validity of screening tests are measured as percentages. Means each of these calculations are multiplied by 100. The specificity here was found as 98.5%. So regarding sensitivity, 74.6, which means that almost 75% of all cancer or confirmed cancer, women with cancer were screened positive. While regarding specificity, almost all, because it is high, as you see, it is 98.5%. So it may be considered that all women who are free from cancers were screened as negative by screening test. Regarding the predictive value of a positive test, which is 11.8%, so the probability of this test to truly detect the disease among screened persons is only 11.8%. So we can say that 1 out of each 10 screened positive will truly have the disease, while the predictive value is higher, of course. The other measures that you should know about screening test is the accuracy rate of the disease. This is measured by dividing A plus D, that is the true positives and the true negatives, out of all persons or populations screened. While the prevalence of a disease that can be measured from these data, it can be measured by dividing the total number of positives divided by all populations screened. So A plus C out of all persons that A plus B plus C and plus D. Of course, we all want a screening test that is both highly sensitive and highly specific. But this usually not possible in all circumstances, because when we increase one, for example, when we increase sensitivity, this will be on the expense of specificity, and the reverse is correct. When we increase specificity, this may be on the expense of sensitivity. So there is a trade-off between sensitivity and specificity of given screening test. This represented by finding there is clearly normal persons that is truly positive, and there is clearly abnormal persons, the true negatives. But in the gray zone, there is the false positives and false negatives, and here is the problem. So if we want to increase one of them, sensitivity or specificity, we should work on the cutoff point or the criteria of positivity of the screening test. So lowering the criteria of positivity will increase sensitivity, and increasing the criteria of positivity will increase specificity. For example, in hypertension, if we take low criteria for positivity as 88 millimeter mercury for diastolic blood pressure, in this case, we are going to detect all those with hypertension, all the positive cases, but at the same time, false positives also will increase, and this will lead to decreased specificity. While if we increase the criteria of positivity for hypertension, for example, if we take the cutoff point as 95 millimeter mercury diastolic blood pressure. This will lead to that we are going to detect all those who are not hypertensive. But at the same time, we are going to increase false negatives, and this will lead to decreased sensitivity. Reliability of a screening test. This refers to consistency of results when repeat examinations are performed on the same persons under the same conditions. Of course, any screening test should be reliable or reproducible, which means that when we repeat this test on the same person under the same condition, we should have the same result. But sometimes there are variability in these results. The sources of this variability may be different. First of all, biological variation inherent in the actual manifestation being measured. For example, blood pressure. You all know that blood pressure, when examined, differs for a person, differs in different circumstances. For example, when a person under stress may have high blood pressure than when he is calm or relaxed. Also, variation may be due to the test method or the instrument that is used for screening. For example, the sphygmomanometer that is used to examine blood pressure. So the instrument itself may be the source of variability in the results of screening. The other thing is the intra-observer variability, so that the same screener may give different results when repeat the screening test on the same person under the same condition. Or it could be inter-observer variation. This is the variation between different screeners. That is, different screeners may give different results or interpret the results differently. And lastly, we will talk about types of screening. There are 3 types of screening that I would like you to know: the mass screening, the high-risk or selective screening, and the multiphasic screening. First of all, the mass screening means that the whole population or subgroup of population had the screening, irrespective if they are at risk of developing the disease or not. The second type is high-risk or selective screening. Here, the screening is applied selectively only to high-risk groups. For example, screening for cancer of cervix by pap smear, a cytological examination of the cervix, is made only on women with lower social groups, because we know in advance from previous researches, there is evidence that this cancer occurs mostly in women with lower social groups. While, for example, for breast cancer, we may do screening on women with positive family history of the disease. The other type is screening for risk factors. Here we are searching for risk factors among persons to prevent occurrence of disease. This type of screening is considered as primary prevention because searching for risk factor, for example, increasing cholesterol in the blood, which may be a risk factor for coronary artery disease, may lead to prevention of further diseases. While the usual screening, that is applying tests in a preclinical stage of diseases, is considered as secondary prevention. And lastly, the multiphasic screening. So this type of screening is done by application of 2 or more screening tests for different diseases in combination at the same time to a large number of people. For example, we do at the same time blood pressure examination, auditory examination, visual examination, hematological X-ray, and any other screening test at the same time on a large group of population in a community for the purpose of early detection of different diseases and provision of appropriate treatment to prevent or improve prognosis of diseases. And that's all about screening.